Good afternoon. Welcome back to our NHS West Yorkshire Integrated Care Board meeting. This is the afternoon session, which is live streamed online and then is available on record as well for members of the public and health and social care staff to review. We have, as a board, just had an engagement session with colleagues across the voluntary community and social enterprise sector in West Yorkshire to hear firsthand and in an informal setting about the opportunities as well as the challenges and barriers that they're facing. And this links with our risk reporting around the sustainability of the sector, which we have concerns about, which is why this is a priority and a focus on topic for us today. So we're now going to move on to item 8 on our agenda, to our focus on the voluntary and community sector. And then, as colleagues can see, we then have a selection of different areas of reporting around good governance and assurance, as well as some strategic and commissioning items towards the end, and we will take regular breaks. Again, Kim, thank you so much for the preparation for this document today in outlining the good practice across our system, the ways in which we already work and the ways that we hope to work in the future. I'm going to hand over to you to do an introduction, and I know, colleagues, you should have in front of you 4 questions, which Kim particularly would like to invite us to think about and respond to. So, Kim, would you like to give us an overview? And thank you to colleagues from the sector who have joined to observe this section of the meeting.
Good afternoon, everybody. My name's Kim Shuttler, and I'm the sector lead for the VCSE on the board. I'm also the Senior Responsible Officer for Harnessing the Power of Communities, which is a long way of saying the programme that works with our VCSE sector as part of the partnership. As Cathy has talked about, and has been talked about a bit in our engagement session, one of the reasons why I'm here is because the sustainability of the sector rates as very high on our risk register. But that's not what I wanted to focus the session on today. And I was thinking this morning, what I really want to do is a really big rallying call. And I thought, what do I want you to walk away with? And I thought, actually, I'd really like you to walk away with FOMO, fear of missing out. Fear of missing out on the opportunities that I think you've heard a little bit about over lunch today. Because the opportunities are fantastic. And actually, I think we're all around this table here for the same reason, that we want to transform health and care, we want to make it better for people, communities, and we want to tackle health inequalities. And that's where I feel like we've got an opportunity that we are missing out on at the moment. So I wanted to just pause just for a second and for you just all to have a little bit of a think about, when it comes to maximising the potential of the VCSE within our partnership, where do you think we are now out of 10? What would you say from your position, maybe from your place or the role that you play on this board, where do you think we are now? And then I would like you to have a think about, what would it look like if that was a 10? So in this paper, you have got some really cracking examples of amazing work. In that room, you heard directly from some of the leaders in our sector about the amazing work that's going on. You also heard about some of the real difficulties. And what I think is, actually, if we were a 10, or if we were edging closer to a 10, that could be really transformative for us. It isn't the magic bullet for everything. But actually, when we look at our strategy, we look at wanting to deliver care closer to homes, to empower, embolden our communities, all the things that we've talked about with some of the leaders in there, this offers some really, really good solutions. So I do want to later come on to the conditions that we might need to create to make that happen. But I really want to start firstly with thinking about some of the priorities and some of the solutions and the ways that we can help to make a difference as a sector. So in the paper, you'll see, and we've got 14,000 organisations. I mean, there's a lot of us. We're a diverse bunch, and I can never sit here and say I'm a representative of everybody. But we've identified 4 areas where I think we're uniquely placed to help and to bring something to the table that complements the things that other people do. So it's not about competition. It's about saying, look, we bring something different and special, and that's some of the stuff we deliver. And a lot of it is the way that we deliver, and the way that we deliver is different, and we have different constraints, but often a freedom and agility and a flexibility that colleagues around the table don't have for various reasons. So I want to share some of those priorities with you and just test out a little bit. Do they feel right? Do they feel like the ones that we should be focusing on? So the first one is around acute and specialist support and services. And that is an area where I think there's some fantastic potential, and you'll see in the paper some examples, and it talks very much to some of the stuff that has been talked about this morning, like how do we help people to wait well? So we have waiting lists, we know that that is the case, and they are likely to increase. But actually, I know that there are pockets of practice around West Yorkshire where they're doing some fantastic stuff, using non-clinical buddying peer support services to address CAMHS waiting lists, for example. And actually, the result of that was that a lot of those people didn't need CAMHS in the end because they had their needs met whilst they were on that waiting list. There's other examples in there, and I've shared one about Master, about integrated teams. So what does it look like when we have truly integrated teams that bring together those specialist, those professions, you know, our clinical professions, social workers, but with non-clinical staff, and are working to address the needs of the whole person. And they're working on things that I hope everybody around this table will recognise really clearly, that admissions avoidance, delayed discharge. So I think it's about moving away from a narrative that still exists, that the VCS is that like sort of nice, fluffy activity that you know that we can easily sort of have in or out. Actually, we're operating at the sharp end and actually operating with high levels of acuity and specialism in a lot of services, and there is a potential of that to really, really grow and develop to address some of those really burning system needs. The second one is about neighbourhoods and communities, and that's our bread and butter. You know, that is us. That's the sector through and through. So 95% of the sector is small or micro. Probably, if I was to take a punt, but it's very, very difficult to guess, I'd say 95% of the funding goes to the 5% or maybe even the 2%. But actually the richness sits in your 95%. So when we're talking about the fuller stock take, we're talking about getting close to communities. Those community centres that you heard from today, who are delivering essentially health and wellbeing hub provision, anchor provision, close to where people live, meeting their needs in a variety of ways, all those social determinants, that work is incredibly powerful. And actually when I've only been in this post since September, but one of the things that I'd pick out as the strongest in West Yorkshire is the work that's going on in that locality space with our sector. Really fantastic models in all of them. But again, I'll return to what if we escalated that, what if we made it bigger, we made it better, we really invested it so it was reaching its potential. And that, but I think it's important to say in that space, and you've heard about that in lunch, that 95% of the sector is your grassroots organisations. It's your organisations who have generations of trust built up with communities who are not hard to reach because those people are reaching them. And those are the organisations that are most vulnerable at the moment. So those are the organisations that are reaching minoritised, racialised communities. Those are the organisations that their work is gold dust when it comes to addressing health inequalities. And we know that on our risk register, the risk of not addressing health inequalities is really high as well. So we need to pay attention to those, because actually the mechanisms that we have in place almost universally exclude those organisations from getting sustainable funding. I think somebody said to me yesterday that the road to paradise is not paved with a series of ABCD small grants that last for 5 minutes. We can't, it can't work like that. Those organisations who are delivering life-saving and changing work are sometimes, they're operating on a collection of 50p's and they haven't got their core costs covered, but actually the return that they deliver, the social return on investment is quite phenomenal. The third one, which is very, very closely linked, is about reach and engagement. And I don't need to tell you about that. I think we can't see the VCSE as a proxy for communities. It's not the same, but I think we are very, very gifted and at reaching communities in a way that often, our traditional statutory services cannot. And I think the pandemic shone a light on that more than ever. I was privileged to be part of the COVID response in Bradford, part of the Gold Command, and I know that we could not have delivered some of that work if it wasn't for those grassroots organisations. They came out in droves, and we couldn't have done it without them. So that's really important. Those people have the ability to reach people we cannot. And when we sit around this table and think about why is this not working? Why is that pathway not working? Why does nobody want to take up that vaccine? Those organisations know, because they've been working in those communities and listening to them for 30 years, forever. And then the fourth one is workforce. And, you know, we've talked about workforce a lot, haven't we? We know that that's one of our biggest challenges is, you know, Rob's talked about it just now, is that we can't, that the NHS and statutory colleagues can't always recruit. If we have the right terms and conditions and pay in the sector, we can recruit, and we can recruit a different complementary workforce that really helps to address some of those challenges that we face as a system. So some of you will know I'm really, really geeky about peer support, about the power of lived experience. I'm geeky about it because I've seen it in my day job, the power of peer support in mental health services. It's just, I just can't even tell you how wonderful it is. And I just think to myself, well, what would that look like if it was bigger, if it was better, if we were doing it at scale, which is what we were all about. So I'll stop there, just to pause, and then I'll come on to the conditions. But I just wanted to ask you, do those priorities feel right? Are there things that are missing? Do those feel like they contribute to our strategy and where we're aiming to get to?
Thank you so much, Kim. That was really articulate. Really appreciate that. And I suppose there's one is sense checking. This is something you're doing since you took on this role, is just making sure that you're moving in the right direction. And I know many of you have this role in how you work across sectors and translate. So I'm grateful to you for doing that as well. So colleagues, does that ring true on what Kim has outlined and what the document says? And feel free to agree or disagree or help develop it further. Jane, would you introduce yourself?
Yeah, I'm Jane Madeley. I'm one of the non-exec members and chair of audit. I just wanted to ask about children and young people, because we don't mention them explicitly within those priorities. So is that because it's kind of assumed within there? Or, you know, how do you target this and ensure that they get picked up through the support as well, please?
So I think the thing about the sector is it works with everybody, no matter what. And the thing that the sector's good at is not being like, this door is not for you. You don't fit into my box. But absolutely, I think, you know, we could draw that out more explicitly. And I think if these priorities are more are agreed today, what we'll do is go away and really flesh those out and say, actually, okay, what does this look like in action? What does this need to mean? There's lots of fantastic examples of children's services and people working with children's and families in a really, really holistic way. I mentioned the CAMS waiting lists and work like that we do. I think the community centres is really important to talk about in the space of children because of the way that they wrap around families in the place that they live. There was a lady out there who was talking about working with disabled children and their families and really, really wanting to emphasise that that's the first stop. That's where people go, not necessarily to their GP, because they know that that's an organisation they can turn to.
Fatima, would you introduce yourself? I'm just wondering if we might have new viewers. So,
Yeah, happy to, Chair. Hello, everyone. My name is Fatima Khan-Shah. I'm the Chair of the Race Equality Network here in West Yorkshire's Health and Care Partnership. My question, Kim, is I think this is a really exemplary paper. I think it really responds well to some of the feedback we've had from our VCSE Voices panel, which feeds into our independent review, about the importance of the value add of certain smaller organisations that are often underrepresented, don't have the appropriate infrastructure to contribute to this. It's really great to see that reflected within the paper. It would be helpful to understand how, in light of current circumstances, particularly several VCSE organisations struggling with the cost of living crisis, etc., how we can be, really innovative as a partnership in supporting that and really addressing one of the key asks of the independent review, which is really thinking holistically about how we design and deliver services and giving power back to our VCSE organisations in the decision-making process as well as supporting the delivery.
thank you, Fatima. And I just want to highlight in Kim's paper, there's around the 7 recommendations as part of our response to cost of living, which we worked on as an overall health and care partnership. And I know, and speaking on behalf of Kim, I know we want to reiterate that today. So that is one element. But Kim, do you want to respond?
I mentioned earlier on about the 95% of the sector being small and micro, and those being the organisations that are really struggling to get hold of the sustainable funding. And a lot of those organisations are that some of the are reaching our racialised and minoritised communities. They are the organisations that do not tend to have the fundraising infrastructure. They hit the barriers when it comes to complicated procurement processes. They just are so, you'll have heard from them today, they are so busy delivering frontline services and being there, whatever it takes for people, that they haven't got time to be attending lots of networking meetings to understand what the new acronyms are in health and care. So the other thing that I want to say is about the need to work on the diversity of the leadership in the sector. We need to, all of us, not just in the sector, but certainly in the sector, think about how we bring diverse leaders to the table, how we hear those voices and make that accessible for them. I would say we've got a lot of work to do on that, and we have to be intentional and invest if we want that to happen in the future.
Okay, thank you. I think we have Hannah, then James.
Yeah, just on the sorry, I didn't introduce myself. My name's Hannah Davis. I'm Chief Exec at Healthwatch Leeds, and I'm here on behalf of the 6 local Healthwatch working in West Yorkshire. Just on the 4 priorities, and it does mention it below, but I think there's just something around recognising third sector leaders as system leaders around the transformation of what we're trying to achieve, which is person-centred holistic care. There is such a lot of expertise and knowledge around delivering services that are not about disease but are around the person and are about linking together mental health and physical health, about meeting people where they are. So there's something around that system leadership role to deliver the model that we say that we want to deliver.
Thank you. If we take James, then Becky, and then maybe Kim, you want to come back and reflect. James.
Thanks, Chair. So I'm James Thomas. I'm the Medical Director for the West Yorkshire ICB. So thank you, Kim, for a really great paper there. I suppose in terms of the transformation that we've seen and you're talking about in terms of how do we, in certain areas, I suppose, scale that up. I suppose the one area I was just wondering whether we could reflect is, I suppose, we talk about innovation, is about the research as a step before in terms of how do we encourage research in an area which is, as you say, challenged, but as a system, from a system level, are we able to help support that research in order to be able to innovate and then also to be able to kind of demonstrate the real value in different terms apart from the descriptive terms we've seen and not just about value. So thanks, Kim.
Okay, Becky, and then we'll come back to Kim.
It verges on the conditions. I'm trying not to ask about the conditions, but if we're talking about those 4 priorities and we're beginning to experiment about this blurring of a boundary between the NHS and the third sector, one thing about the capacity of those small organisations, Kim, is that there's a capacity to deliver. There's also a capacity to contribute to learning alongside the NHS, which is a very big organisation, has some investment and funding for learning. So how are we going to both know whether it's working? How are we going to learn about the best model together if there isn't that sort of support for the third sector?
So, Kim, you've got comments there around voluntary and community sector. Colleagues are leaders in system working. How do we encourage research? When we're blending boundaries, and I've seen the work going on in Bradford, particularly about how we learn together, but how do we blend workforce as well?
Sure. Thank you. In terms of system leadership, I mean, firstly, I probably would like to say and recognise that I think there's very few ICS boards around the country that have somebody from the VCSE sitting on the board. And the fact that that West Yorkshire's decided to do that is a real mark in the sand. There's other really strong areas of practice in our places where they've really recognised and invested in that through their infrastructure. So I know in Bradford there is an investment in a VCS system lead who sits alongside the chief executives like Mel, and at a senior level, and they're recognised in that way because their contribution around the table is really, really valuable. And it's not just about ticking a box and saying, OK, we've got the VCSE there. It's about recognising that they bring something different to the table. So, yeah, absolutely, James, and I think we can only do more of that. I think we can only diversify that. In terms of... Oh, sorry, I can't remember. I don't think it was James who said about system. It was Hannah. In terms of research and data, I suppose what I would say is there is actually a lot of research and data which evidences the impact of the sector. I think what we could work on together, and of course we could do more of that, and that would be important to do, but I think what we could do more and differently is to capture the rich data and insight that we have within the sector already. So sometimes I have a look at some of the insight and research reports that come from the universities, and they're fantastic. They're really good. But I sort of think to myself, oh, we could have written, all of us could have written this, because actually from that insight that we gather every day on the ground, it's amazing, but we don't use it. We don't use it to inform our decision making, our policy, and our strategy. And I think as a sector, it's a challenge. Well, we all have challenges with data, don't we? But actually, how do we articulate our outcome data in a way that is understood and enables us to make the case for, I suppose, the additional investment in a way that is understood by, colleagues at NHS England, for example, who have very specific metrics. So I think that's something we can work on together, is how do we draw that line so that you can see that very easily, but make it proportionate, because we don't want to create a cottage industry of these amazing organisations spending all their time counting beans and not delivering the work. And the last one about learning together, yes, I think we have that learning, we have that insight, but we have to fund it. We have to, if we want people to come and share that insight and be around the table, we would have to fund that.
Thank you, Kim. We've then got Jo and then Robin. Would you introduce yourselves? Jo first.
Is that on? So good afternoon, I'm Jo Webster, Accountable Officer, Wakefield Place. Thank you, Kim. I think the paper's great. I've already shared that earlier today with Kim directly. And I think the recommendations of places offer us the context for a conversation in our committees, which I'm sure my colleagues around the table would share. I just wanted to share my thoughts on the funding. And one of the things that the Wakefield Mental Health Alliance has recently brought to our leadership team's attention is a discussion around how we might get better at understanding across public sector how many grants and short-term funding pots we give to the voluntary and community sector, and how much we could change the way in which we do that by having a different and more robust commissioning, as I would say in its broadest sense, opportunity to make sure that the totality of that resource goes to the areas that we need. And I think that would help the voluntary and community sector through my conversations I've had with them, because a lot of that funding that they receive is got so many metrics that they spend all their time filling in forms and monitoring the metrics rather than their contribution to an outcome. So I think there's that I think would be helpful for them. And I think it's the unintended consequences. So I sit across, as you know, 3 organisations, and sometimes the left hand doesn't know what the right hand's doing. And so the unintended consequence of a grant stopping in some of these smaller organisations through the local authority on then the impact that they're having on some small pot of money that they had from health is profound for that organisation. And I think it's having a shared understanding of what resources are going in so that we can get more benefit from that is the first start, and then building on that for future funding. So that I'm quite happy to share. We're calling it a Funders Alliance in Wakefield, so another alliance, but hey ho, it sounds like a good one.
Jo, thank you very much. And I think it is the right thing that we as commissioners and contractors should mix the cocktail of funding and not expect the voluntary sector to do it all the time. It's exhausting for them, isn't it? So I think that's fantastic. We've got Robin, then Carol, then Mel.
Yeah, thank you. It's Robin Tuddenham. I'm the Chief Executive of Calderdale Council and Place Lead for the ICB for Calderdale. I guess I wonder if we could one thing we could do today is make a pledge that Kim or anyone that may come to this board in the future after Kim doesn't sort of have to say that it's a good thing that you're at the table. And it's not a good thing that you're in Bradford having conversations as a VCS with the Chief Exec of the local authority and the NHS Trust Chief. And do you see what I mean? So I suppose it's aspiration that stops being a good thing that we have to comment on. That's just the thing that we do. And I think all of us probably, we've been doing 15 years, would be in that situation. So I suppose it's about the potential in this partnership to raise our aspirations and our ambition. And I think in that there'll be some difficult decisions and some challenges. So, money is tough. There isn't enough of it, and it's not in the right place. So one thing that we've just done as a local authority is agreed a 5-year commissioning framework for the voluntary sector, all infrastructure organisations, all advice. Not every single bit of money that goes to the sector is in that frame of reference, and it's not enough, but it's kind of something around the stability of the money, and that we bear the risk rather than the sector. And I think there's a bit of shift in power there. The other thing I think is the one advantage, and it's very much work in progress, so I want to say that, of a local authority NHS collaboration like Calderdale Cares is that we are thinking about a place like central Halifax and the cost of living impact, and so we're saying that the UK SPF money is going to go just there. The Core 20 plus 5 money is going to go there, and we're thinking about how that money works to really make the maximum impact. So let's use the money together better. And I think the challenge in the sector is the strength is also a weakness. So if it's 95% is that small organisation, how do we grow community anchors that have a parity of esteem and an influence? So Halifax Opportunities Trust started in 2005 as a New Deal for Communities programme, regeneration programme, with 4 or 5 people. It's now £6 million turnover a year, social enterprise that runs early years services, that does stuff around work, does stuff around health, and is a community anchor with a lot of influence in the place. That creates some challenges, because other parts of the sector may say, hang on, is there a sort of equal voice here? But I think there's something about shifting to some core anchors that have that ability to really influence and shape public services in the place and some decisions to take. So I guess my challenge is whether we could get to that over time and cease to see just being at the table as good enough, really.
Okay, thank you, Robin. I think we're, by chance, going round to hear from each of our place leads. So, Tim, I might come to you afterwards, and we can hear perspectives from places, and then we'll come to Sarah as well. So, Carol, and then Mel, and then Tim, if you're willing, from a Leeds perspective, and then we'll come over to you, Sarah. Carol.
Thank you. I'm Carol McKenna. I'm place lead for Kirklees. And you're right, we're hearing a few things from places that will be consistent, and I am pleased that in Kirklees we're moving the conversation on beyond the seat at the table element. So we've always had a representative from the VCSE in our place committee, and we have that replicated in many of the other elements of our infrastructure as well. So for me, it's not so much about representation anymore. It's about moving some of the conversation on to pick up some of the things that I think both Joe and Robin have talked about. And so at that point about strength and weakness bit was in my head as well, and it became very well. It's always been apparent, but one of the conversations we had at lunchtime was that benefit that a lot of our voluntary organisations have, in that they're right there in neighbourhoods, they're working at that community level. I think the downside of that, obviously, is that sometimes it's then how do you influence up, how do you get into that bigger geography conversation? And I think the slight concern I have as well is that because we associate working in communities and working with our voluntary sector colleagues so much with working in our places, that means there is potential, the funding risk becomes different in different places. So, if we have conversations about the challenges facing local authorities who are large funders of the voluntary sector, that all local authorities are facing funding challenges. Some are of a greater order than others. And does that mean then that voluntary sector in different parts of our organisation at West Yorkshire level are exposed to a different level of risk depending on that financial picture? And I think that's something, if we're to ask the question, what can we at West Yorkshire do? Getting some clarity on that and some understanding around what we do about it, I think might be something that we can take that, that helicopter view on, rather than just saying it's purely a place issue. And then within places, the conversations for me, it's about moving it on from the sort of commissioner and contractor with the voluntary sector to the partnership as a whole. So I don't think it's just the organisations that used to be the CCG or the council who are the potential funders for the voluntary sector. I think a number of our statutory providers can fund the voluntary sector as well, because often money that we might be giving to Brendan's organisation or Karen if she was here in Locala, or I know the Mental Health Trust do a lot on this already. Equally, some of that could be used to subcontract, that's the wrong word, but just for speed, you know what I mean, with voluntary sector organisations. And that might mean that for those smaller organisations, they've got the benefit of a larger organisation to manage some of the, I hate the word bureaucracy, but you know what I mean, the systems and processes that surround some of this work and can make it difficult for the smaller organisations to engage. Thank you.
Thank you very much, which comes back to a point earlier on risk management as well. Okay, we go over to Mel, then Tim, then Sarah.
Thank you very much, Chair. Mel Pickup, Place Lead for Bradford District and Craven. I want to say three things, really. Firstly, thanks to Kim for the vision and the passion that really comes across incredibly strongly. We had the benefit of Kim being our person representing and advocating for this sector in Bradford for a long time, and we felt the benefits of that. And that mantle's been picked up by someone for whom we have now agreed to fund a full-time post to give that individual greater capacity to be involved in, not just representing a seat around the table. I think it really opens up the opportunity for that person to behave much as our other leaders of different sectors in a distributed leadership model. So to take on greater responsibilities in a distributed leadership way, leading on something on behalf of all of the place in Bradford District and Craven. The second thing is to say thank you for the recommendations, because I think they're a really coherent way of inviting, if not instructing and advocating, encouraging place leads to take them back into their places and have really good conversations, as Joe's alluded to, because you've done a lot of the legwork for us in being really explicit about the kinds of things we should be talking about and pointing us in that direction. And the third thing I wanted to say is, I think it's really important that we, as we aspire to elevate and utilise this sector in a very different way, that we maintain the integrity of it and not try and make it behave more like the NHS. So it comes back to that, how we contract and commission and the expectations that we place on the sector. I think it needs to be preserved in its uniqueness and for the special things it gives us over and above that which we already have. And we might need to think about that, because there will be a temptation to oversimplify and potentially impose ways of working on the sector that will crush it, in my opinion. So I think we need to be just mindful of that.
Thank you very much, Mel. That's really helpful. We go to Tim, then Sarah, and then can we come back to you? And we've probably got about 10 minutes or so after that. Tim.
Yeah, thank you. Tim Riley, Place Lead for the City of Leeds. Thank you, Kim. As Mel just said, a really, really passionate case for the third sector in both the way you introduced it and the paper. And I'll come back to that in a moment. So a few things I just wanted to reflect. From a Leeds point of view, I suppose it's almost to back up your assertion about the importance of that infrastructure investment, because Leeds has invested for quite a long time in infrastructure. And that means that the third sector is involved in just about every forum you could think of in some way or other, in terms of around decision making and thinking and development and so on. And also it has led to, and Sarah may touch on this, but others, nearly all our statutory organisations have separate relationships with the third sector and commission services directly. And if you want, I don't quite think it's subcontracting, but there's an element of that to some extent. So those are really good and positive things. Still got a long way to go, I think, particularly when we think about digital and those and enabling Also, our workforce academy is starting to really engage with, and is engaged with the third sector, and third sector engage with them around development and so on. So lots of good opportunity by investing in that way. I suppose then I've got some questions, because I sort of think everyone I speak to is really passionate about this. So the will is there, but it doesn't seem to quite produce the result. And I'm reflecting on this quite a lot at the moment as we go through financial planning and planning round from an NHS point of view and local authorities. I don't think we've adjusted our processes to make the difference. Our processes cut across our ambition. And we're going to end up in a position where that gets more and more difficult, but it is actually quite hard to change. And we need to acknowledge this isn't necessarily about getting will and culture. It's about the practicalities of some of the processes that we have that cut across what we do. And really simple things like the recommendations, took those back into place. The immediate reaction to recommendation 1 is, as NHS statutory bodies, we can't forepay money for services. Our auditors will be all over us. Now we can, but the real catch on that is particularly those that are financially vulnerable. Well, that's the exact group you want to give the money to. So there's some really, really important things that we will need to do collectively and be bolder about, but that needs collective ownership and a degree of risk-taking that I've not seen so far. The third thing is this issue around communities and so on. You're absolutely right. Most third sector organisations are actually quite small, work very closely in communities. One of the reasons they are challenged to engage is, again, nearly all our processes and decision making happens at a place or above level. We don't devolve to that level. And I don't see us really devolving it. We have local care partnerships in Leeds, and a lot of you will have neighbourhoods and other things, but we haven't devolved true decision-making to that level. And until we do, it's not just the community and third sector that can't engage, it's everybody else that works in those places. So I think there's a challenge that the third sector is bringing in an insight into, if we can't engage, what is it you're all not doing right? And are there other people, general practices, others in those working in those communities that aren't able to make decisions about how resources are deployed? So I think that's where a really good challenge comes from this conversation to all of us about how we might do that.
Thank you, Tim. That's really helpful and insightful. We've got Sarah, then Rachel, and then Kim will come back to you. And I'm sorry, then we're going to run out of time nearly. So, Sarah.
Thank you. Sarah Munro, the Sector Lead for Mental Health, Learning Disability and Autism. I just want to say also welcome the paper, and anyone close to the work that we do within our sector know that working hand in hand with VCS is absolutely integral to the models of service we provide. And even within the programme I chair, we've now got VCS leads that are the SROs for our programme, such as Community Mental Health Transformation. I think there is a challenge for us, which we're starting conversations with, is it comes down, and I know Kim has got strong views as well. In a sector that's heavily regulated in terms of our data, what data is allowed to count, and in particular access data. So we're intentionally changing structurally the models of community mental health to widen access and recognise that when people need mental health support, they don't necessarily need what the NHS traditionally offers. And so we're just starting to roll that out, which is completely reconfiguring the workforce model in partnership with the VCS. And similar with children and young people's access. And we've got great examples of where we've used NHS money for the key worker pilot, which has gone to a VCS organisation direct to work with young people with autism to prevent admission into Tier 4 CAMHS beds, and evaluated really, really well. And in fact, some of the feedback from families is we've got more confidence in it because it's not the NHS, because if you've got a child with autism, your experience of the NHS is typically waiting and delays and all of those other challenges. But at the moment, as it stands, with the new operating guidance for next year, if you look at the widening access for adults, access and older adults mental health services, it is only counting core NHS access. So we've raised that. I've been chairing a regional meeting this morning with national colleagues, and it's not a criticism, but sometimes the system just gets itself in a muddle. So we've got a programme of transformation doing the right thing, but there's an absolute delay in the data system to enable us to capture that properly. And I think the challenge for us then is if we don't get that right, when we've got ring-fenced monies such as the MIS and the SDF monies, if we're held to account in an ever-challenging financial system of you've got to spend it on the stuff that's measured, and we'll only measure the access into an NHS organisation, that's a threat in terms of the transformation we want to do. So we are having those conversations, but I think we need to broaden it in terms of, I suppose our plea would be just give us full devolution and we'll demonstrate the outcomes rather than count on what we choose to spend our money on, because that's the best thing to do.
Round of applause there, I think you got there, Sarah. And I think this is something that we've got in our integrated performance report. We talked about our last board development session about the metrics we're being measured by NHS England, but where do we need to go back and educate and inform and bring the case studies, as well as what do we want to add to that in terms of metrics. So I think thank you, Sarah, that's really helpful. Rachel, then Fatima, then Kim, I promise we'll come back to you, and then Rob, I know you've got some final comments as well. Rachel.
Thank you. Rachel Spencer-Henshaw, Director of Public Health, representing the Directors of Public Health for the West Yorkshire ICB. It was just 2 points to add to what's already been said. I do think, thinking about sort of the other players in this, if you think about businesses, they have a level of social responsibility, and I think evidence has shown that often they use that sometimes to fund things like nationally recognised charities that may not have an actual local footprint across West Yorkshire. So for me, there's something about how we sort of work with our local businesses to reflect what actually is the VCSE within our local places and across West Yorkshire, rather than the kind of, oh, we'll do a charity day and give everything to Macmillan. No disrespect to Macmillan, but obviously it's something about understanding our sector from a local perspective, particularly for those local-centred businesses. And then finally, I just wanted to talk about West Yorkshire Combined Authority, because actually it would be really good, I think, if this memorandum of understanding moved to something we could work with them on as well. Because if you think about the Police Crime Commissioner funding, that funds quite a big chunk of the VCSE sector, building on what Carol was saying. So for me, there's something about how we can kind of, what's our next ambition with this? I appreciate we're not going to eat the elephant, as it were, and get it all right, but I do think there's a West Yorkshire angle to this, which would include those different elements of the system.
Thank you. We're now going to come to Fatima, but we won't lose that point on working with West Yorkshire Combined Authority. And we had our Joint Public Health Director start yesterday. I had a cup of tea with Jen and talked to her about ways of working across our health and care partnership and our ICB. So that is obviously a green shoot of how we can work together. We've got Fatima, then Becky. And we will come back in a minute. Fatima.
It was just to follow on from what Sarah said. We, Sarah and Sima and I, went to the Young in COVID Routes to Recovery launch last night, which was an absolutely phenomenal evening. Harris was there too. And one of the really insightful things from the film was a reflection about the utilisation of services by young people from ethnic minorities in particular, and the fact that they will not use services if they don't reflect their communities or share the lived experience of those individuals. And another thing that really struck me was the role of faith in health and how the VCSE sector can really support that too. So I think, you know, the revolution that Sarah's leading, I'm fully behind her. I'm happy to make that a reality. And I think Rachel's point about the West Yorkshire Combined Authority and a joined-up way of working is a really good suggestion too, and hopefully something we can work on.
Thank you. Becky.
Just three things. Listening to this session with our colleagues this afternoon about can we do something? I suppose the first thing is, can we please ask our winter planning folks to think about how we're going to make sure we have a more standardised and appropriate response to the third sector next year. So it's not that we stand them up, we stand them down, we stand them up, we stand them down, that we embed that. So that was the first thing. The second thing is, can we please ask our fuller group just about the issue around estates and primary care and third sector, and a collaborative approach to that. It felt that felt a really practical thing that we heard this afternoon. And the last thing is just your equity of investment, Kim, on page 71, there's always that risk between bespoke and small and asset-based and community and standardised as a whole. But can we just make sure what we're doing is fair across all our places? And that may be something we can pay attention to as a group here. Thank you.
Okay. There's a lot to go at there, Kim. I hope this is giving you assurance in the intended direction, and it feels like it's perhaps coming back to us in what happens next. But what are your thoughts from the comments from board colleagues today?
So I really appreciate everybody's support. I think, you know, what I was really pleased with what Tim said, because I would have said that as well, is I think we're really lucky to have fantastic advocates around this table. I think, you know, we're lucky to have one of the best, most vibrant VCSE in the whole country. But unless we do some things quite radically different now, urgently, we won't have that anymore. There's other areas of the country who've had their VCSE decimated, and I don't want to be sitting in this position to say, because we haven't managed to tackle some of these wicked issues, or it sits in the too hard to do box, or processes get in the way, that actually we see our sector diminish significantly, and that is happening every day, that we don't do something radically different. So I suppose just to round up the conversation, I'd remind you of, please let us get to a 10. Our people deserve that, and we all deserve that, because that would, it would solve so many problems, but deliver some fantastic work. And I'd ask all to go away and think about being really bold and brave in how you then take those decisions, both in your place. And then, are we agreeing those recommendations today? I'd really love that we agree those in principle. Obviously recognising those need to go back for consideration at place. And can we do something now? Like, can we see some action so that we can see some real results for people?
Great. Thank you, Kim. I wanted to invite Rob to share his reflections as well before we finish up on this item.
Yeah, so real change happens in real work, doesn't it? So we need to do some real work. I was really taken with the paper showing there's about 1,000 fewer organisations. Was that what it showed in the stocktake? In existence, so the idea that organisations are disappearing is real. I think I've got 5 points and a suggested way forward. So the first is, I think Carol made the point about the state of local government finances and how that might impact. And in the private part of the meeting, we're talking about money, and we've got a report from our local authority partners, and I'd be interested to see whether it's covered. And if it's not, we should have a conversation about it. Second, I think Joe talked about the Mental Health Alliance and changing the way that we relate to provider collaboratives. And I think often when we talk about provider collaboratives, we might talk about WIAT, the Association Acute Trust, or we might talk about the Mental Health Learning Disability Autism Collaborative, both doing brilliant work. Increasingly, what we're talking about is multi-sector collaboratives in place. And in our heads, we should always think that's the third sector too. Because that's the reality. When it comes to things like winter monies, Becky, sometimes you get them so late, you're like, we can't recruit anybody, but we can spend it meaningfully through the third sector. So there's a bit of agility required, which is always helpful. So I think that's the second thing. But this is about provider collaborative development in places, which is a big thing for us next year. It's part of what Tim's looking at. I think then in taking this forward, my sort of simple brain said, the stuff around conditions for success, that's what the Harnessing the Power of Communities programme is doing with places and with the enabling programmes on digital, capital and people. So I think it says, look, for places there's things you have to do, and for the system there are things you have to do here. So somebody needs to work out, is that happening? And I thought, well, that's the Harness the Power of Communities. We're giving it permission to work with places and with those enablers to say, is this happening? So just to give an example, yesterday I was at the Shared Care Record Conference, and they were talking about, Leeds Community Foundation and various third sector organisations in conversation with the programme to make sure that the third sector can get involved in the Shared Care Record. So somebody needs to be doing that work. So I think we're agreeing that those look like the right conditions, and Harness and Power of Communities programme needs to work with places and the programmes to make sure that those things are being delivered. And similarly then, the fourth thing I thought was that the priorities that we all say, yeah, they're the right priorities, they need to sit somewhere. So there are programmes of work going on those priorities, where what we're saying is the Harness the Power of Communities in the third sector supports the delivery. So it sort of inverts it. It says, for the people board, have we got the right input here? Because there's some recommendations here that we're going to have to get in place, and we're going to have to wrestle with some, real tangible issues, and grasp some real opportunities. So I think what we're saying is, as we get into the operating plan delivery, the 4 priorities need to sit with work that the operating plan's delivering and the third sector contribution needs to be recognised and supported. I think that's what we're saying. And the last thing I think we've said, which wasn't in the paper but has come through really strongly for me, is we need to have a bit of coverage. We need to connect some stuff, so what Police and Crime Commissioner's doing, what broad local government's doing, but we also need to deliver some air cover for people at this board, because they might want to do something quite radical in place. And that takes us back to the board assurance framework. Is our risk appetite set at the right level to do that? So I think this would be a really great paper, really clear. Huge amounts gone into making it that clear and simple, I think. But we've really got to get on with the doing now. And I think that's the way I would recommend we get on with the doing, if people agree.
Okay, colleagues around the table, are we supportive of this direction of travel, principles, ways of working, conditions of success? I wrote down in my notes, we have a memorandum of understanding in place with the sector, but how does this translate into action, which is what you're inviting us to move forward with. Now, if we had another hour, I'd invite us to talk about community asset transfers, how to do long-term and better commissioning and contracting, how we give core funding to very small micro health and wellbeing hubs rather than just project hand-me-down money. There are lots of different things I think we can work on, and I'd invite you all to take something away from this. I think someone used a pledge over here. I think, Brendan, you might have said that, or Robin, sorry, that we pledge to do something. So this is one of the moments where I invite you to pledge to do one thing as you walk out of this meeting, as well as what we'll do is write this all up and work with you, Kim, to support you in delivering this with many, many, many people across the sector. But I think we just remember that your point, Kim, is around these are micro-organisations, so how do we work with them at place level, in neighbourhood levels, which colleagues on this side were talking about, and how do we take the right kind of risks and make this accessible? So do you want to have the last word on this, Kim?
So we're all proud to be part of West Yorkshire. I think we're one of the best ICSs in the country. If there's one that can crack it, it's us. So let's give it a right good go.
Thank you, Kim. Thank you so much. Okay, and colleagues who've joined us from the sector, really grateful for your time today. I know there's a number of people who joined us over lunchtime across places, and we commit to writing up the informal discussion we had and the notes from here and taking this forward together, and we can respond back to the sector through Kim and harnessing the power of communities as well. So thank you. Okay, great. That's great. Thank you very much, Kim. We're going to move on now into the next part of our meeting, which is our oversight and assurance. And in some ways, I'd like us to take item 9, our integrated performance dashboard and performance report with finance, item 10 on winter performance, we've got item 11 on corporate risk register, and 12 on our committee AAA reports, which, as you know, are across all our places, as well as our integrated care board committees. They should, if we're getting the reporting right and the governance processes right, they should all link together. But we will, for minutes and discussion purposes, take them in the order that they are, but we will work through these together. I invite colleagues across who are representing and advocating for sectors as well as places to share with us what's working well, the barriers they're facing and anything the Integrated Care Board can do to support. There may be things that we need to do above and outside of West Yorkshire, and that might be lobbying and discussions regionally and nationally, which Sarah was talking about earlier in terms of mental health provision, as well as we can do to support you in your services and sectors and places. So first of all, we've got our integrated performance dashboard. I want to thank colleagues who've put themselves forward to be part of a task and finish group to develop this further, so it works for us in West Yorkshire as well as delivers for a number of colleagues and partners, including NHS England. And we've got that piece of work over the next few months or so. I want to welcome Deborah, who's, I don't know if you want to give us an overview, Deborah, and we're happy to take questions.
Hi everybody, thank you for letting me attend today. My name's Deborah Taylor-Tate and I'm representing NHS England on behalf of Anthony and Lou, who couldn't be here today. So I'll take it that you've all looked at the report, and I'm just going to go over a couple of the main areas within the report. The first one I'm going to look at is around the electives. Obviously the electives, there's a lot of focus on our elective recovery, and our ambition is to have nobody waiting longer than 18 months at the end of April this year, which we are well on track to have the majority of those seen. Next, we will be looking at 65 weeks, and our ambition there is to have 0 by the end of March 24, and that will all be within our operational plan, which I know is on later on the agenda. Diagnostic waiting lists remain static, and we've seen a definite steady improvement over the last 12 months, and we are also on track to see 95% of people in 23-24 no longer waiting more than 6 weeks. Cancer, just check out on cancer, faster diagnosis, we are achieving the 75% of all people being seen faster diagnosis, but then we do have further work throughout, obviously the Cancer Alliance, to look at the other targets that we've got around the 2-week wait, the 31 and the 62-day standards. Urgent care, obviously lots of focus on the urgent care, especially with the recent issue of the UEC recovery plan. You can see there from our A&E targets, we do not meet the standard for the A&E targets. That fluctuates anything between 62 up to about 72. But we're working very, very hard, obviously, with all of the places, and our planning ambitions for our A&E targets is looking around 76 at this moment in time. Bed occupancy, again, fluctuates extremely over the last quarter. And again, we are looking to reduce that in line for obviously the standards that we need to meet within the operational planning. And currently, we're about 96% bed occupancy. One of the areas where we face the biggest challenge is around our ambulance service. We have not met the target around the category 2, and we are working very, very closely, and I know many of you are engaged within the meetings that we have regularly with YAS. We've been working very, very hard with them during the planning, and we are hoping to put in a plan around achieving that for around the 30 minutes, but that relies very heavily on system support. And we've had many discussions over the last couple of weeks with systems on how they can support YAS to reach that. And I think it's been a really, really good discussion. Obviously, achieving the category 2 is not just reliant on YAS, it's reliant on us as systems, looking at alternative pathways and reducing conveyance rates as well. IAPT, if we look at IAPT, our IAPT recovery, we're nearly meeting the percentage on that, but our IAPT 6 and 18-week performance is good, and they're both above the targets. When we get down to general practice, we are meeting all the standards around general practice for appointments and seeing on same day, and we are expecting, I hope, by next week, the new access recovery plan, which will detail the work that we are expecting to happen in general practice over the next 3 months. And that plan would look like it needs to be delivered by the end of June and July. They're the main points that I want to pull out. I know, Jonathan, you're going to talk a little bit about the finance, but if there was areas I think that we would want to focus on, I think the majority of those will be included in the UEC recovery plan, and we are waiting for the new board assurance frameworks around urgent care to come out within the next week or so, so we will be able to bring that to the next meeting.
Great. Thank you, Deborah. Jonathan, do you want to give us an overview? Would you introduce yourself?
Of course. So thank you, Chair. Thank you, Deborah. So I'm Jonathan Webb, Director of Finance at the ICB. There are 4 finance indicators in the system oversight framework that I'd just like to draw the board's attention to. The first is around delivery of the ICS and ICB financial plan for 22-23. At month 10, we were behind plan on a year-to-date position by £6 million. But that I should say that's in the context of a £4.8 billion budget. The forecast at month 10 was to deliver our financial plan both as a system and across the 11 statutory organisations across West Yorkshire. What that will mean is that the ICB will finish the year with a £4.4 million surplus, and the consolidated aggregated deficit position across the 10 providers in West Yorkshire will be £4.4 million deficit, so an overall system balance, and that position hasn't changed from previous updates. Supporting that are the financial efficiency plans, again across all 11 statutory organisations. There was a small shortfall on the year-to-date position at month 10, but we are continuing to forecast delivery of in excess of our plan. So we plan to deliver £293 million worth of efficiencies. That should end up being around about £315 million. And that additional stretch was as a result of additional cost pressures faced by organisations in the year who had to find mitigating measures to manage those. The third indicator is around our performance against the mental health investment standard, and again we continue to deliver positively against that and forecast to achieve that for the year. The final standard is around spend on agency, primarily across the 10 provider trusts. We've got a target from NHS England not to exceed a target of 99 million. We have continued to forecast above that for the last few months, so we're now forecasting around about £20 million overshoot. We've been through the conversation in Finance Investment Performance Committee about why that might be, but happy to go into further detail today. The Finance Investment Performance Committee sort of continue to review all those 4 indicators in a bit more detail.
Okay, thank you. Does anyone have any questions at all or comments? Or we can take an overview on the winter planning update and take the 2 things together. But I don't know if there's anyone got any specific questions at all. Jane, then Harris.
Yeah, thanks. Thanks, Jonathan, for that update on the finances. Could you just say a little bit more, unpack a little bit on the agency position and what the view of NHS is with that overshoot, and how do we plan to sort of get it back down within whatever targets will be for future years?
Thank you. And some place colleagues or indeed provider colleagues might want to comment on this. Clearly, in terms of efficiency and in terms of quality of staff, continuity of service, etc., generally the view is we want to use agency staff as least as we possibly can. Having said that, there are specific workforce shortages in certain critical areas, and where that's the case, provider trusts have got to take a view in terms of balance of judgment. And it's not quite as straightforward as this, Jane, but if on balance of risk, if it's around not staffing a critical service that requires consultant cover in CAMS, for instance, or in another specialty, or breaching a target, a financial target around agency specifically, particularly given that context of us continuing to forecast delivery of our overall system position, that's the balance of judgment that providers will often take, and that's the conversation that we've had in the Finance Investment Performance Committee. But other colleagues may want to comment on that.
I can comment.
Yeah, I guess I'm interested in terms of how NHS are responding to that.
So NHS England are aware of that because we report it to them on a monthly basis. As I said, Jane, we understand that we are not alone in that regard. I think at the moment I'm not entirely clear on what that will mean in terms of our system oversight framework performance level at the end of the year. We'll have to we'll have to understand that as we go through. It doesn't appear to be at the top of NHS England's worry list at the moment, but I'm conscious that this meeting is in public and they might take a different view.
Okay, all right, thank you. I mean, I think it's just interesting. I'm not disagreeing with the reasons and where we may have to make those calls. It's just, I think it's appropriate for us to sort of understand how that is perceived in terms of future planning, etc. Thank you.
Thank you, Jane. Brendan, did you want to come back? Yes.
Well, I think Jonathan's ably described it, but the reality is it isn't just about winter. We've had additional beds opened for months, and that's due to the complexity. I'm saying complexity rather than acuity of our patients, and therefore those beds need staffing. But it isn't just a conversation about the agency costs, it's also what else can we do. But there is a workforce shortage in this, but we are looking collectively about our bank or peripatetic offer. And if I think about some of the work we've done in some of the places, Calderdale and Kirklees, what we've done is work with our local colleges so that T-level students now have a paid placement with us. So in addition to the learning that they have to do as part of their T-level, we've offered them a bank contract. So this is how we flush out and expand some of our peripatetic offer. There's the whole debate around pay. But this is absolutely about additional beds and therefore additional staff.
Okay, thank you. I think we've got Harris, then Becky, then Sarah.
I've just got a quick comment on the A&E wait times. March 2024 is a very long time away, and for children, it'd first of all be good to see some data on how many children are waiting longer than 4 hours in A&E, because we talk about harm, but we need to think about the emotional harm on a child that's waiting in that accident and emergency environment for longer than 4 hours and what damage that causes to them. So just a quick comment.
Thank you, Harris. And this is about getting greater insight in the information that we're reporting, which is really helpful. Okay. I can see colleagues nodding around the table. That's possible, Deborah, to give that insight in that data?
Yes, definitely. Just a bit of assurance, Harris. Children is probably about the best performing area. Obviously, we've got separate A&E departments for all of children and really specialised CAT units for children. But yeah, we'll dig that out for you.
Great. Thank you. Okay, Becky, then Sarah.
Thank you. Deborah, we've had in these papers the last couple of times in the report, I think it's 4.2, there's going to be real-time data available. It doesn't say when. So it's really important that we have real-time data. We're one of the ICSs that doesn't have it, so when are we going to get it was the first question. And then secondly, just in our role about understanding variation, there's 2 points of variation that stand out. One is around A&E waiting times, that we've got quite a range across the patch. And the second thing is the amount of appointments per head of population in general practice. So it sort of varies between 500 and 650, and do we understand the variation of what's been made available per head of population? Thank you.
I can take the primary care one. I'd have to go away, Becky, and find out about that. I think both of those charts need a lot more work to understand what they're actually trying to tell us. Plus, obviously, there's not so many targets attached to them. So I think there's a great piece of work we need to do around the primary care. With the A&E waiting times, yeah, again, there is variation within that. And I think I looked at the data over the last couple of days when I knew I was coming here in a bit more detail. And we had a conversation yesterday, me and a couple of my colleagues, and I think there definitely is something coming out in that data that we would not recognise as well. Around the real-time data, I mean, obviously that's something we're working on that we can pick up. I can pick up now if you want to pick up about the radar, which is in the winter update. We're working really closely with NEXT. We've got the first part of that real-time data starting to come through, and that includes YAS and the acute sector as well. So we're starting to get a lot more information that's available to us throughout the day through the radar app, and that will give us our A&E waiting times and our bed occupancy. The next phase of that is to start to work with primary care. We know we've got that in Leeds and we've got that in various other areas, so that will start to give us and understand the pressure on a daily basis that's happening in general practice as well. Obviously, there are other areas that we need to start to get that data from, the mental health, and it would be great, Kim, that at one point our ambition was to try and get something like that, obviously, from the voluntary sector and feeding them more into those daily conversations that we have around the escalation and where they can help, I think is a really good ambition that we need to take forward. But I'll take all of these comments back and obviously we'll get back to you. But I think I totally agree with you around the primary care. I think that's definitely where an area the task and finish group needs to look at in a lot more detail.
Great. Thank you very much.
Can we get the timescales for the data? It's when I know it's all happening.
The primary, the radar.
Yeah, the real time
stuff. Yeah, we'll definitely get those.
So some of these things we'll do as a follow-up by an email, as a follow-up immediately to this meeting, and other things will come through committees and reporting. I wanted to invite Richard in advocating for primary care. I don't know if you want to respond to Becky's comment, and then I know we've got Sarah, then Ian.
Yeah, no, I'm very happy to. I mean, I'm sure Becky appreciates the quality of general practice appointment data that's gathered is very, very poor, and it reflects of the complexity of general practice. How do you possibly compare, a 5-minute urgent appointment with a half-an-hour sort of booked appointment? Is it one appointment for each, or is it sort of the equivalent of 1 and 3 or 1 and 5? It's very, very difficult. And what type of appointments count? I think it's a minefield, sort of, in actually trying to unpick all of this when you've got so many different providers as well involved, counting things in different ways, and maybe different districts counting things in different ways as well. Across our region, I think there's a real challenge here.
Okay, thank you very much, which was why we wanted to get together and try and solve this conundrum. And for anyone who's looking at the documents online, there's page 10 of the Integrated Performance Report outlines the national measurements, metrics and targets that we have that come from NHS England as a basis. Want to come to, if we take Sarah and Ian together, no? Okay, Sarah.
Yeah, it was just to come back to the question that Jane was asking in relation to agency costs. So the specific challenge within mental health is the shortage of specialties within consultant psychiatry, and that's been a long-standing issue. But just to give reassurance, as of next year, we'll start to see a higher proportion of higher trainees coming through for consultant posts because of the widening number of medical school placements. So we are hell for leather, looking after them, enticing them, courting them with a whole series of events over the next couple of months, with everybody going along and saying, you know, come and be a part of this fantastic place called West Yorkshire. And a lot of them train with us and really have positive experiences. But in the meantime, we have seen for the first time this year success with international recruitment in psychiatry. So we've had a decent cohort that's mean we're starting to reduce the number of locums and support them on to achieve their consultant grade qualifications, which is a big step change within psychiatry. So it's definitely something that we see that we'll continue with as well.
Thank you, Sarah. That's really helpful. Hannah, did you want to come in?
Yeah, I suppose I just wanted to say, in terms of the figures we've got here around the NHS performance metrics, they sort of tell a different story from the experience of people as well. There's lots of really positive activity within there, isn't there? So, but I suppose it's just because all the figures that you were presenting there, Deborah, they were in the majority positive, weren't they? But there's a lot of work that we know that needs to happen to answer the issues that people are saying out in West Yorkshire around, for example, in mental health, the wait for CAMS and wait for IAPT, and then having to pay privately for counselling. You know, there's lots of things that people are talking to us around, you know, people's variance and GP access experience. So, and I know we want to measure what's important to people, but that does feel really important. Not least because these figures say that you know, we're doing the things that NHS England tell us to do.
Sure, and this is where we want to have two lenses or different aspects that we want to look at for our health and care partnership. Rob?
So I think Hannah's hit upon something that's really important in this conversation, which is the national standards that are being set and the constitutional standards are different from the national targets that we've been set and the ambitions nationally. So 75% of people being seen, treated, admitted or discharged within 4 hours in A&E isn't the national standard. National standard is 95%. And it's the same with the Category 2 calls. So we've been asked to work with the ambulance service and our partners to create a system that can deliver a 30-minute average for Category 2 calls, but that's not the standard. So I think we need to do a couple of things in our operational planning. We should see if we can go further and deliver better than that and closer to the national standards, because they're set for a reason, based on what people want, and also usually to do with quality or safety considerations. So the second thing we should do through the Quality Committee is to continue to keep an eye on what's happening then as a result of us not delivering to a set of standards that have been delivered in previous years or set as ambitions. And if we see that there's harm, we need to do something about it. So I think it's really important for us to keep an eye on that. So, you know, we need to do the right thing as well as the required thing.
Okay. Thank you very much. So with the integrated performance report, we've got some immediate actions on additional data, giving us some depth and greater insight of what we have now. The task and finish group are going to meet for at least 3 to 4 months. So our aim is by the July and then into the September meeting, we might have something a bit more rounded, a 3D model, as it were, of what we're trying to look for. And a bit like we've done with the board assurance framework, then we test it out for a while and see how it goes for us. And as I said, when we met as the task and finish group, there aren't many examples out there for us to go and learn from. But if you see any in a neighbouring system, in another sector, in another country, then please share them, because we need to learn and we're all restless to improve this as well. But Deborah, thank you for that. James and Deborah, we just introduced the winter planning report, and I was just having a quick check-in with Laura. I wonder if for our next meeting it acts as a chapter to our system reporting in future. But is there anything you want to highlight, James?
Yeah, thanks, Chair. So this report is brought to you having been through the finance and the FIPSI Also, it's a winter report on the Winter Board Assurance Framework. It's also associated with the Urgent Emergency Care Action Plan as well there. It builds on previous papers that we brought to the board back in November and January. What I'd like to highlight is that it is demonstrating month-on-month improvement with the implementation of our action plan as a system there. And it also confirms that additional funded bed capacity has been opened and that our system controls centre has been launched as was requested nationally as well there, and we're building on that and working on that further as well. Just to highlight in terms of table 3, at the end of February, just to highlight that 35 of the 51 required actions, that's 69%, were fully implemented across West Yorkshire there, and 16 were partially implemented. Where all those all actions which are not fully implemented are having ongoing work in place to complete them with the risks and controls kind of identified there. I'm going to hand over to Deborah in terms of a bit more detail there, but also to highlight in terms of we have done a winter review, which I'm sure Deborah will pick up on already, to understand some of the challenges we've had and also the successes we've had, and also going forward what that means for now and for next year, or later on in this year, I'd say there. So I'll just hand over to Deborah if that's okay.
Thank you, James. Just on the BAF, just to talk about, it finishes at the end of this month. So we will be bringing a final report to the board in May. We know that, I think I mentioned it before, there will be, based on the new UEC recovery plan that came out as part of the operational guidance, we're expecting a new board, a new assurance framework, and we think that will be heavily focused on all the additional capacity and the additional investment that we've had through the operational plan. So I think at the next, if we're bringing the final report on the BAF, we'll obviously be able to bring a report that starts to understand the impact of that and the reporting requirements for that. Just a little bit more on the winter review. I think it was absolutely fantastic that all of our systems started to think that we should do a review early. We haven't even started it by now, and I'm normally the one that says make sure you do it. So it was really, really welcome that everybody decided that they wanted to do it in February. All systems came together, and I think it was great that they were all able to share and showed real collaborative spirit in how they're wanting to work together to obviously manage and address some of those challenges around winter. But I do appreciate what people have said. It's not just about winter. We're facing those pressures all of the time. But what it sort of brought out was what we do well, what we need to do better. And I think one of the big things that came out about well was the way we work as a partnership and around that escalation and the OPAL escalation that we do on the daily basis. Obviously that pulls in the SCC, and more recently it pulls in our EPRR around the strikes that we've been experiencing. So I think all of that was a really, really positive, and the radar that I mentioned earlier obviously starts to build on how we're managing that daily demand and the risk that we're taking across all of that systems. One of the things that always comes out is that share of risk, and I think there's a lot more work, and I know, Bev, we've talked about that, a lot more work that we need to do going forward about how we're sharing that risk across the systems. A great thing about that event was it feeds into Easter planning. So as you can imagine, I've asked for that assurance already. And of course, the May bank holidays, where I think we will be required to provide quite a lot of information about what's happening across the system. The radar app is a big thing for us at the moment, and as I said, I've mentioned that and how we're going to be taking that forward. But one thing, just to pick up on what we were talking, the voluntary sector came out quite a lot, Kim, within the winter event, and how we can use that. So there may be something we want to work with what came out of that review going forward. I think that's a real opportunity that we would want to pick up on. I think that's it around winter. I think that's everything. It's been hard, but I think as a system, we've dealt very, very well with it. We recovered on a daily basis, which I think was really encouraging with a lot of our trusts. We're escalating, and then within 24 hours, we're de-escalating. So it's showing the processes are working, but also that out there at place and trust level, they're working very closely together. So bring on the next one. Is all I can say.
Okay. And I think there's something that you've shared there, which when I was reading the report about how this is a winter planning report, but actually it's informing Easter and then it's informing May. And I wonder with our reporting whether we're looking at system performance and system pressures and the learning. And I appreciate then there are the different metrics for winter and in general. So I'd welcome that learning. I think this is really helpful. Rob and I have had conversations with national colleagues who are really interested in how we're learning, how early are we learning. So someone we met nationally suggested that we start learning in February. And I'd also invite, again, any good practice case studies on integrated working, including around the Better Care Fund, which I asked for at the Partnership Board meeting on the 7th of March, because I think these are really helpful to take outside of our system and share with regional and national colleagues as well. Does anyone have any comments or questions? Rob, and then Bev.
Yeah, so thanks for the report. It's really helpful to see. So the board assurance framework set by NHS England, the nomenclature is unfortunate, isn't it? It's not a BAF as we'd use elsewhere on this agenda. I think, we might bridle at the amount of detail in it. It also includes a lot of good stuff that we should be really learning from. So my question really, Deborah, was just to make sure that the board was assured that the learning from the event was being picked up by the Urgent Emergency Care Programme and by the A&E delivery boards in place. Is that the route through? Okay, thank you.
It was focused at the A&E programme board last week. It was a big focus of that, of what came out of it. So, yeah, and that will go through to the A&E delivery boards.
Thank you. Bev, then Ian.
Thanks, Chair. Beverly Geary, Director of Nursing in West Yorkshire ICB. So I just want to acknowledge the amount of work that's been carried out by the team and congratulate them for doing this so early, because usually, speaking from another life, we start winter planning in summer. So I think the learning that we brought from last winter that Rob has already mentioned was probably one of the worst that we've all experienced. Is really good to do it as early as we have. I think the other thing, just to reinforce, is the way in which we worked as a partnership across West Yorkshire and actually to mitigate those risks on a daily basis that our patients were experiencing. Escalation. And again, we did talk, Kim, about voluntary sector in those Gold Command meetings on a daily basis. How can we, link with all parts of the sector? And I think the other thing is, thanks for mentioning Easter, because it's a 4-day bank holiday and it's always incredibly tough. So I'm hopeful that the early learning from this event will go into planning for the coming weeks. Thank you.
Thanks, Bev. Ian.
Thanks, Cathy. Ian Holmes, Director of Strategy and Partnerships. It was a very similar point to Rob's, actually, was around closing the loop on the actions from the learning event. And I mean, it looks great, and the list of recommendations look really strong. It feels to me that it's potentially a bit broader than the UEC board and the Place A&E board, so I'm happy to have a conversation afterwards about how we connect to those. I'd suggest we also bring something back here, probably in the summer, in terms of planning for next winter, so we're not waiting until the national stuff comes out to demonstrate how we're doing on these things.
Great. Thank you. And we did, I think, challenge Anthony Keeley, who's our colleague embedded from NHS England, to bring that in July, which he agreed to. Deborah, did you want to come back before we move on?
Yeah, just a point on planning. I think I absolutely appreciate everybody said we sort of stop it and then start it and stop it and start it. So I think we need to make a commitment that it's continuous. So I think we have done learning, we feed that into our Easter, then we'll get another, can you provide assurance for May bank holiday, then another one. So I think we just need to consistently do that, and we've got some ideas about how we can set up a bit more of a robust planning group that meets throughout the year, that tackles anything, around planning and all the pressures that it faces, that would include things like winter, BCF and all those other things as well. And now we feed that into the operational plan, the joint forward plan, and then through to the strategy, because it's continuous now, and we need to recognise that it is continuous, and the requirements are. So I'd like to get ahead of it, not wait for them to ask us. We've got it ready for us. I think that's a really important thing for us.
And then in taking it forward, if we're always looking at system performance and system pressures, we can build that in each time and having it as a standing agenda item. We've got Rob, then Hannah, and then we'll take the next two agenda items together. Rob.
Yeah, I was just going to, again, just to make sure we close the loop. So I think what we're recognising here is that the way that we work, the way we do things around here has changed. And we, for example, required to have a system control centre that operates 24/7 throughout the year. And we've talked about continuous planning, and I think Brendan's reflected the fact that beds are open throughout the year that would have been closed previously. We've got Tim doing a review of the operating model in the light of running cost allowance changes, and I think we need to factor in this sort of way of working into that review. So we should just ask Tim to pick that up.
Which he's noting down. Great. Thank you. Hannah?
It's a sort of a tenuous link, but I suppose that, particularly with the focus on the review of the planning of dealing with huge, significant events for the NHS and social care. We've talked a couple of times about learning as a health and care system from COVID and what we did differently and what we will take forward to that. And I'm just wondering where that piece of work is, and if not, can it come back to the board?
I can see you nodding, Rob. Is that possible?
Yeah, we did an early piece of work. Some colleagues were involved in and some weren't, about with the Academic Health Science Network on what were the conditions which allowed us to innovate during COVID. Not what were the innovations, what were the conditions. And I think it'd be worth us thinking about that again in the context of new operating models to make sure that we're doing the right things. In terms of the additional work, I think Bev and James were involved in looking at that. I don't know if there's anything you want to say about Quality Committee or anything else picking up lessons from COVID, but I would centre it in those. What were the conditions that allowed us to innovate? How do we build that into the innovation work that James has been doing, and how do we link that into the operating model?
Great, which we can take into committees, into places as well. Okay, colleagues are nodding around the table. Great, thank you. Okay, thank you for that. And I think, as I've said, if we can combine those two documents together, and I know in talking to non-exec directors as well, any analysis, any areas where you want to highlight good practice or barriers or areas of non-assurance, or where there's a mitigation in place, that would be really helpful in taking us forward in that reporting. So the next item we've got is Corporate Risk Register, item 11, which are the current risks within our system. And then item 12, we have our committee AAA reports across our places and across our integrated care board committees. Now, the aim is in our reporting and our governance that these should connect in some way. So, Laura, if you talk through the corporate risk register, we'll take the committee AAA reports as read. Though colleagues who have been authors or part of that, please let me know if you want to raise anything, and we'll take questions as well. So, Laura.
Thank you. Yes, I'll just provide a brief introduction to the report. So you've got details of all the risks that are currently on the corporate risk register, together with details of the place risks that are scoring 15 or above. We've also identified common risks across the places, and there are a number of risks that are proposed for transfer from place risk registers to the corporate risk register. The report provides an update on the work to develop the risk register during this fourth and final risk cycle of the year. A number of points I wanted to just draw to your attention. There are 5 new risks this cycle, which have largely resulted from work to include risks where there were felt to be gaps during the last risk cycle. So you'll see cybersecurity and also sustainability related risks. There is 1 risk marked for closure as it's no longer deemed relevant. We have 5 open risks currently rated as critical and 4 as serious. The number of critical risks has increased this cycle, and I would encourage the board to specifically focus on those highest level risks. The Risk on a Page report is designed to give you a range of information at a glance, and this time I've started to include narrative about what the trend data may be showing, as after 4 cycles we are starting to see those trends develop. Again, I would particularly draw your attention to the static risks. So those are risks where the score has remained static, it's remained the same since it was first included. And we have 2 critical risks that have been static since July, so just draw your attention to those. You've also got information within the report around risks that are deemed to be common across 2 or more places, and also the feedback from the discussions that have happened in the West Yorkshire committees and feedback from place committees. As always, the report does contain detail around the processes we follow from an assurance point of view, but I would encourage the board to focus on the detail of the risks themselves as opposed to the process. Thank you.
Great, thank you, Laura. And then in item 12, we have, as I said, the committee AAA reports, and you can see there where colleagues are sharing information to advise or assure or to create any alerts to come to this board as well. So in taking the 2 together, because I hope they do combine together, do colleagues have questions, comments, or would like to share any further information at all? Jane. and then Tim.
Thanks, Cathy. A couple of questions, particularly around the risk report, which is, there's a huge richness of data within this and no doubt behind it as well. So I guess there are a couple of specific points that I was just interested in asking questions on, and then sort of some reflections on how else we can help ensure that we're kind of covering that within a board discussion when time is tight, etc. So just on the specifics, I'd be interested. Obviously, in the critical, there's quite still capital infrastructure elements that are flagged there. Obviously, it was the spring budget last week. I wasn't sure, didn't see myself whether anything had been announced, and I think there'd been a hope that there might have been something. So I was interested to hear anything behind the scenes insight on that one, please. I was also interested in the reporting from the subcommittees, the reflections on it, where they mentioned about recommending that a children and young people corporate risk might be articulated that hasn't been to date. So I'd be interested to hear where that is being considered. So those are my two specifics. And I guess I was, obviously in the place reporting that comes forward here in Appendix 3 and 4, there's a lot coming forward from the place or being reported in the places in the critical and high risk categories. I think the common appendix that picks up the commonalities is really useful and kind of has some theming around it. And I'm just thinking whether going forward there can be something that sort of maps what's within here that's either picked up in agenda items in the board meeting, so we can kind of say, yeah, we know we've got that covered, or signpost where things haven't been picked up, how they are being progressed, particularly where there's commonality and what discussions are taking place around that, rather than is it just being left in that place to deal with. So that's more sort of, generally, I guess for Laura, how we're thinking about that going forward. Sorry, a few questions there.
Jane, I think that's really helpful, and you and I had a discussion and getting together with non-execs last week about how there might be some priority kind of reporting and summary narrative with some data, and then there might be a number of supporting documents. So the feedback's really helpful, and we can test out a way of doing this for the May and July board meeting. Your point as audit chair is that we need to be talking about the priorities and the risks, don't we? Okay. Capital. Jonathan.
Thanks, Chair. And thanks, Jane, for the question. No, we are still waiting to hear the announcements from the new hospital programme in terms of what that means for both the Leeds Teaching Hospital scheme, but also any other bids that we have put in, which we have through West Yorkshire. I guess there's probably sort of just two other things I'd add to that, really. So we've got a conversation lined up at the April Finance Investment and Performance Committee to consider in some detail all of the strategic capital schemes that we've got on the chocks within West Yorkshire, with a focus really on if they don't progress at the pace that we would like, and it's unlikely that all of them will progress given the value, what are the mitigations and where does that leave us in terms of risk? So I suppose that's the first thing. I guess the second thing that's given rise to that particular risk being flagged in the way that it has through the risk register is not just about those big strategic schemes, but also about our operational capital. And that's really from sort of two perspectives. One, which is around, is that sufficient to deal with the estates risks and the infrastructure risks that organisations think they carry at the moment? But also, if there are sort of mid-scale schemes that straddle the big new hospital programme type scale and the operational capital scales, things that sit in the middle, how do we as a system address and support those? And again, what's the risk-based approach to that? So the general approach that we're sort of going to take through the Finance Forum and the Capital Infrastructure Board is to ensure that those risks are flagged through organisational risk registers, through place risk registers, and then up to the ICB board, because we have got the overall accountability for certainly the operational capital bit within the system.
Okay, thank you. And just to note, we continue to support all our providers who are looking for national funding for capital. We included it in our last MP West Yorkshire wide briefing, for example, and also when Rob and I had our first meeting with the Secretary of State as part of all ICB chairs and chief execs across the country, meeting with a senior person in Department of Health. We also raised it there and followed up with information. So we can keep colleagues updated and also on those lists, but you can see also those capital priorities coming through in the AAA reporting from place. Jane, do you want to come back?
Yeah, I just wondered whether that was really helpful, Jonathan, in terms of where these things are going to be picked up. I wonder at one of the boards following those April conversations, maybe we could have an agenda, because it often gets picked up from the risk register document. Maybe we could have a paper that kind of outlines where we've got to, and maybe by then we will have heard about the new hospitals, but you capture the various elements, and so we're all cited on kind of where we're concluding on those.
Yeah, yes, by all means. I mean, what might be helpful is to circulate the briefing that we recently issued to MPs, to all board members, because I think that gives a really helpful 4 or 5 page summary of where those schemes are at.
And we can bring it through in the Finance, Performance and Investment Committee. I know I've used this term quite a lot today, but that watching brief, this is an area of concern for places, providers and for us at system level as well. Sorry, Jane, you had a question on children and young people. Could you just ask that one again?
Yes, I think in the summary of the subcommittee discussions around the risks, there was a point that was flagged as a suggestion that we should have something that captures children and young people's risks at the corporate risk register level.
Laura, will you respond?
Yeah, I can briefly, and those who were at the Quality Committee might want to reflect. So I think it was recognised that a number of our places do have a risk relating to children and young people and neurodiversity, and there was a feeling that actually, given that that's on a number of place registers and is a priority, that we should be looking at putting something onto the corporate risk register. As we start the new risk cycle towards the end of this week, there'll be a prompt in order to capture that risk.
Thank you. I think we've got Tim and then Carol. Did you want to come back on that, Rob?
I just wanted to... Well, I'll come back at the end, it's fine.
Okay. Tim.
Thank you. You'll be aware that there isn't a AAA report from Leeds because we only met last Tuesday, so it was too late. So I thought I'd just give you a couple of updates of the sort of main things on that. 3 really big discussions and 2 which were alerts. Well, the first alert was around the financial position. So the financial position for next year and the financial planning were discussed in detail. That remains a significant concern, as it does in many places, and a real challenge. And I know we'll talk about that more later, but that was certainly discussed in some depth. The other area that we did discuss, and we've just touched on it there, was access to neurodiversity diagnosis, particularly for children, but not just children, adults as well. And I think that probably goes back to an earlier conversation we had around the way waiting lists were referred to, and the sense that in some ways it does feel as though we are really slowing up access. We are just not in a position to meet the current demand, and there's a real cultural change underway that we have not yet caught up with, and I know that's a conversation we're having across West Yorkshire. The third area I was going to mention, we did discuss it, it's probably not on the alert because it's always been on the alert from Leeds, which is around flow in particular. What was good about that, and I did want to just particularly note this, is we are seeing improvements around that area after quite intensive work over the last year or so, particularly the last 6 months. Just to give you a taster of that, we've seen through winter, we've seen a reduction in terms of our no reason to reside percentage of beds occupied from 22% to 17%. That's against a national increase. So we're pleased with that, but whilst recognising 17 is still too high, we need to go a lot further. Rather than 7,000 lost bed days, we're down to 4,800. Again, that's really positive. That means people are staying much less time in hospital than they were before, particularly long waiters. And we've also now got a new tool in place that allows all the system to see in detail, including social care, hospital data, community data, where people are in the process. And we've seen a reduction in one of our community care facilities in their length of stay, which is always hidden, is never shown in national reporting, of 50%. So again, that's the first area we've really worked intensively to do that. So we're making some progress on that one. The one other area, and this just refers back to John Prentice's question earlier about how we ensure that we don't, with the focus on sort of disease and comorbidities and so on, that we're expecting, lose sight of mental health. One of the pieces we've been able to do, because for the last few years we've been really investing in how we bring data together across the council and the NHS and segmenting the population, we're able to identify the population group that has 3 or more long-term conditions and an SMI, and our long-term conditions population board and our Mental Health Population Board are working together to really address and do some work on that. And that's enabled us to put a bid into something called Seismic. I'm not going to try and remember exactly what that stands for, but it's a big national research bid process that we've put in with the LAP, the Local Leeds Academic Health Partnership, and universities, which will really look at how we improve processes for those people, particularly targeting health inequalities. So I think that's sort of the kind of answer that we might want to think about when we think about long-term conditions. What we do know, and I'm able to sort of bring it up on the data, is when we look at the, for example, hospital attendance or GP attendance of people with 3 or more long-term conditions and an SMI, it really stands out as markedly different from the general population, which is why we're focusing on that area.
Thank you very much, Tim. And we'll make sure that's noted down in the minutes. And colleagues, that's a really helpful update from Leeds Place as well. There's something in what you're talking through there, Tim, around tackling inequalities. It sits as one of our own strategic board assurance framework risks, as well as the better improved use of data. These are themes perhaps we want to bring into the next few meetings as well. We've got Carol, and then Becky, do you want to come in? And then if we haven't got any more questions, we'll then take a break. Carol.
Thank you. So in terms of the Kirklees Place Committee, we have actually met again since the AAA report was submitted for these papers. We met on the 8th of March. So there will be an update on that, obviously, coming back to the next board. Just to give some reassurance, though, we did pick up in that committee a report from our own quality subcommittee where we'd done our deep dive on issues such as neurodiversity, and we've got one planned for children and young people's mental health at the next meeting. And actually, we also received a report there about some of the work we've done around things like screening rates. So to pick up Rachel's point from much earlier in the meeting, and understanding the variation that exists across our PCNs in relation to screening, some really innovative work going on there with public health colleagues and others to focus on that. So just to tell you that now, you'll see it again coming through in the report. The main thing I did, though, just want to ask, sorry, this is a bit of a processy question. I find it really helpful to see the place comparators, the themes at the end, but I think we just need to be clear about where in our processes we're doing the moderation, because I've already picked up a couple for Kirklees that don't look right. And I can understand why likelihood might be really different in different places. I'm not so sure about why impact would always be different. And whether that's in the exec team or in the groups of our governance leads, there's probably something for us to take away just on that to have a look at.
Okay, thank you. And I can see colleagues around the table, and Laura, as well as our governance lead, nodding there. And I think that can be something to come in to our governance review, which is now live over the next few weeks. We've got Becky, then James, and then Rob. We wanted to come back to you. Becky.
Just the no reason to
I knew you were
resign
going to say
language.
that.
And I am glad we are finally going to tackle it. And I really hope at the next meeting we're not saying that, and we are saying ready to leave hospital, stroke, go home.
Thank you. And I know our colleagues on our ICB Quality Committee are looking at the right terminology that feels person-centred. So thanks to those who've been starting that discussion last week. And thank you, Becky. Mel, do you want to come back on that? No? Okay. We'll go to James, then Mel, and then we'll come to Rob, and then we'll take a break. James.
Yeah, it was just to pick up in terms of some of our colleagues already mentioned about the neurodiversity and the commonality across, and obviously in terms of the potential in terms of a risk there. It's just to highlight and reassure the board in terms of at West Yorkshire, there is a deep dive happening in all ages in terms of, and that's working with people with lived experiences, working with professionals, this year, kind of focusing on what kind of consistency in terms of the pathways, in terms of diagnosing across West Yorkshire there. It's also about understanding good practice in terms of post-diagnostic support for those individuals. And also one of the issues that we've hear a lot is about the right to choose and implementing that and getting consistency across the system. So that's underway at the moment in terms of deep dive. It's all age, although it's recognising there may be differences in terms of the age groups as well there. So it's just to kind of assure people and make the board aware, given it's been brought up.
Okay, great. Thank you. Robin, do you want to come back in on that? Okay, in turn. And I'd also welcome any non-exec insight into, have we heard sufficient information from places? I think it's from a non-exec point of view, that would be really helpful. Okay, Mel.
Thanks, Chair. I just wanted to point out in relation to bullet point 4 on our report that we have had the Ofsted report published in Bradford since we last met, and you will note that all of the domains were rated as inadequate. Both Rob and I sit on a Children's Improvement Board that's chaired by a Children's Commissioner appointed by Secretary of State, and particularly of note, I wanted to highlight that on the 1st of April, the Children's and Families Trusts goes live and will take over the running of children's social care in Bradford. We will work incredibly closely with them. I have met with the Chief Executive, Charlotte Ramsden, along with Therese Patton, who is Chief Executive Bradford District Care Trust and our designated place lead for children's services, and we have welcomed Charlotte onto the Partnership Leadership Exec Group.
Thank you, Mel. That was one of my questions, actually, so that's really helpful update. Robin, you want to go next?
Yeah, I just want to add on the alert we referenced. I mean, it was a few weeks ago, but in the financial position this year has improved, but the risks remain going forward, as Tim's described, I think, and it'll be picked up later. Just the point about workforce, I think we haven't talked much about social care today, and you'll be aware that there is some shift in some of the national investment around social care that's been reported at the end of last week, potential reduction of £250 million of investment, and I don't think I can say enough about how serious the challenge will be, and it links into winter, it links into resilience, and it links into a workforce pipeline and plan or lack of that I think is a systemic major risk for the whole partnership and the whole country, actually. So I just want to say that that isn't really a Calderdale specific issue, but I know we have some specific challenges around our place. The other thing I just want to highlight, it's the practice merger is one of those things that sometimes happens in our system. I just want to sort of reflect on the fact that we had nearly 3,000 public responses to the consultation on that. There have been times when the whole borough has done a consultation and has not had anything like that. And that's just 2 practices, and we had about 30 people at the meeting. And I just think to remember the importance of primary care, your GP, your primary care person, and how much that's so important in the lives of our communities, really. And just again, the sort of kind of the universal experience of primary care is something really important, and it was a really good conversation, and I think a really good piece of work. And I just commend some of the equality impact assessment of that, because it's straddling central Halifax, which is the most, I guess, diverse and deprived part of Calderdale. So that was a really important meeting, and just to sort of note that, really.
Thank you, Robin. I remember you sharing that with me informally about a great example of public participation as well, which is great. Do we have non-execs? Do you feel that we've got a flavour of places through reporting, through the risk reporting, through the AAAs? You may want to share now, or we can share afterwards. But Jane.
Yeah, I think we've got more from it today. I'm kind of wondering whether it be helpful, because there's so much in the risk report. There's still, there's a lot of criticals and high risk scoring for each of the places. Some of them feature in the AAA reports and the discussion, and obviously it's not going to be a common every place committee meeting having the same conversations, but maybe that suggestion to Laura of kind of mapping through so we can see where they're being dealt with, responded to, etc., where the oversight is within the places, so that we can feel confident that they're covered, and you don't need some further conversation here. I think that's when we see all the red and black, you kind of need to see how it's being closed down. Thanks.
Thank you, Jane. And I know all places have been reporting on financial concerns and challenges, and I hope what you can see as a board, we've got a finance report that we've had in sort of 2 chapters today within the board meeting in public, and we will be then convening into a board meeting in private as well. We'll be looking at that again. So it's how we, perhaps we need to be more explicit as well as how we plan this. Becky, do you want to?
It's a comment across all of it, really, which is that I would be really helpful if places could say what their ask is of the board more. So I was thinking about the neurodiversity deep dive, the conversations we've had as I've been out in place about the nice guidance not being particularly fit for purpose. We don't think for this, the sorts of things we might need around early diagnostics and whether that's the right, whether we've got that right. So the board's role in advocating as well as the board's role in assuring. And so we could get a bit caught up on the assurance side rather where we can be active on behalf of and with places. And I think that was just a theme across all the papers, really, please.
Great. And I think as we talk to regional and national colleagues as well, I'm very happy to come out of every single one of these meetings with a list of lobbying points for us to take together. Capital's a very obvious thing that we're all working on together. So, and Sarah shared something she's doing herself, and one of us at least around the room might be able to help with that. So, okay, thank you. Rob, can we come back to you and then we will take a break?
Yeah, so I was going to pick up Becky's ask point, because I think it's, we don't want to be the place where people feel like they're just going to come and get a hard time. There's something where, actually, I want something from you. I need some air cover. We talked earlier, didn't we, about air cover, or it might be money, or it might be a bit of capacity, whatever it is. I think just a couple of reflections and then just a question for the board, really. So I was really good to see the deep dive stuff around autism, ADHD. And, you know, it was good at lunchtime to talk to Dave from Nova about the West Yorkshire Autism Diagnosis Service, which sits in Pinderfields but is available across West Yorkshire for families who've just had a diagnosis. And things start to feel like they're changing given the interventions that we've got, but we've got a huge amount to do. So it'd be great to see things coming out of the deep dive, which gives us a better perspective. Because I think that's a good example of something where, you know, the NHS has a role in the diagnosis, but systems and partnerships play the key role in what the response is. Because most of the response has nothing to do with health, they're social or educational responses. And that's where the power of the partnership comes in. And I think that's similar to the children's point. So Mel talking about an inadequate rating by Ofsted for children's services in Bradford. You know, she and I sit on the improvement board. There have been improvements. The SEND inspection showed significant improvements with the re-inspection, and there's a great amount of work going on there. But this organisation, this board of this organisation, you know, we are playing a role with our place committee in overseeing the improvements. So we've decided that that's okay. I think we are actively deciding that's okay here, aren't we? Mm-hmm. So you've said, you know, Therese and yourself working with Charlotte as the Children's Commissioner are going to make sure that there's a good route into this. And that's interesting. It's different, isn't it, from what you normally expect in an organisation, but it's reassuring that the response goes beyond the NHS, it goes into the partnerships, and those partnerships play through the governance that we have. I think the question I've got for the board is, we've got a principle here, which is, you know, organisations deal with issues themselves. If they can't, they get support from their peers or places. Can't do it in places, we have to do it in West Yorkshire. Can't do it in West Yorkshire, we have to do it nationally. If it's a national, if an issue is caused by a national policy or decision, we have to get that action at that level. If you look at the capital risks that are on the board papers today, we're sitting on critical risks, which are on the corporate risk register, which require a national solution. So there are two. There's the overall capital availability, and then there's Airedale's RAC. And I just wanted us to make sure that we were happy with the degree of action that we are taking in getting a resolution to those and what timescales we want to set on them. So as I was just totting up, so we know that Airedale RAC will be considered as part of the Future Hospitals programme, and we're expecting there to be some kind of announcement very soon about what will happen to resolve the issues at Airedale amongst all the other RAC hospitals. That's the word on the street. So that hopefully will get addressed through the Future Hospitals programme. The Linfield Mount issues, which are in here, which don't make pleasurable reading, which are being risk managed through BDCT. They don't make pleasurable reading. That's going to be Future Hospitals programme. It's either in or it's not. And if it's not, we'll need to do something about that. We've then got the Leeds as part of Future Hospitals programme. It's got a bit of a delay in terms of the 2 new hospitals. We've got Bradford Royal Infirmary as a sort of more of a future focus thing. So it's a bit longer term. It's not necessarily as big a risk at this point, but will be in the Future Hospitals programme. We've then got Leeds and York Partnership Foundation Trust. So by July, is it, Sarah, there's a next checkpoint on the PFI in Leeds and York, which is 5 years away from running out. And when you're 7 years away, you start to engage with the National Infrastructure Authority around what you're going to do. We're now 5 years away, and in 5 years' time, those buildings will revert to the ownership of the PFI company, unless we buy them or do something different. Now, we need a solution to that, and that solution hasn't been forthcoming yet, and it requires some national decisions. So we are influencing the system to say, now, we need a solution by this checkpoint. Calden and Huddersfield Foundation Trust, some really good conversations going on nationally with colleagues around how we progress the work. Now everything's signed off, but it's still waiting a national decision. So I'm just conscious that we've got a range of stuff there, some of it which is 20 on our risk register, which we're all sitting here accountable for, but somebody else is going to make a decision on. I think we're doing enough of the kind of engagement and lobbying on that, but we probably need, don't we, to say by July, we need to have had some movement, otherwise we need to take some different sorts of action.
Yep.
I just think it's worth the board clocking that, really. Yeah, good.
Thank you, Rob. Lots of nods around the table. And I think there's something that our Finance, Performance and Investment Committee can keep oversight. We have a West Yorkshire Capital Forum, don't we, Jonathan, who obviously are looking at this consistently. And I think there is that, what is the option B, what is option C? And that might be different kind of lobbying, or it's different kind of work, or it's different kind of funding. So thank you. Yes. So we'll commit to the action of sending the briefing out, same briefing that we've sent out for MPs, which gives more detail than what Rob has just taken through there, but it also gives more detail and background in comparison to the reports. Brendan, do you want to come in?
I think I'd support Rob's point. If decisions aren't made, or the wrong decisions are made, actually I think we need a different conversation here about why are our patients and our communities not entitled to a standard of care? Why will they continue to be cared for in less than adequate facilities? So we will need to completely revisit our BAF, Laura, I'm sorry. We will have to revisit this. I think Hannah made a really good point about there are people behind the figures, but there are experiences behind the figures, and it's how do we capture some of this? And I'd argue some of our communities are already being cared for in suboptimal facilities. So we will need a different conversation if either a decision isn't made or the wrong decision is made.
Jane, do you want to come back?
Yeah,
sorry.
I guess no, it's fine. I was just thinking, so the MP's letter that we've sent previously, it sets out what the issues are. I guess I was, think what we need is if we don't get the response that we need, want, etc., then I do think we've got to have the articulation of exactly what does that mean, what is the best we can do to mitigate it, what are we having to do, but something that is really clear in terms of the risk for our population that we are having to bear as a consequence of that. Because with the best will in the world, the scale of funding that's required for the cumulative, I think Jonathan would be doing really well if he could rustle that one up in the absence of. So, but we need to be really well sighted on the risks to patients as a consequence. And I think it needs to go a bit further than just the sort of which are the schemes and where are they currently sitting, please.
Okay.
Yeah, and I think we just need to recognise that if sometimes you can play a trick and you add all the money up and it sounds like a massive number because you want to say like you spend a lot of money, and sometimes you make sure that you recognise you don't spend all the money at once and you spend it over the medium term. And actually, when you look at the business cases we put together for the investments that we want, they tend to pay for themselves over time. So it's not just about, a lot of these things make economic sense as well as having a value for quality. I would hope that the risk register sets out the mitigations that are in place today for the suboptimal circumstances that some of our services find themselves in. If not, we need to make sure that they do. But Brendan's point's really well made. I think what I'm pointing to is that at some point we've got to say we've been dealing with this for a long time now, and we have to do something different.
Yeah. Thank you. Mel.
I think it's a follow-on to that speaks to the point Jonathan was making. If we do find ourselves in that situation and we have to think about what are we going to do about it, we know that the capital regime in NHS England usually comes as discrete parcels to do certain things, and you either do those things and take the opportunity to do access that capital, or you don't. In the spirit of subsidiarity, if it is the only capital available, should we be arguing that we need the capital but we don't want to do those things? And actually what we may need to do are some of those bigger things that we don't have at our disposal, but we may if we put a lot of little things together.
Thank you. I'm going to bring the discussion to a close. Jonathan.
Yeah, I mean, this is a really, really important point, and I'm going to sort of typify NHS England's approach to capital. It's more sophisticated than this, but there's the new hospital programme stuff, which is the really big sort of multi-billion pound things. There's the operational capital, which we get 160 million a year to basically sort of keep the show on the road. And then there are a series of almost like policy initiatives that span in the middle. So things like the community diagnostic centres, things like digital initiatives, things like the targeted investment fund schemes to promote elective recovery. What NHS England moved away from a number of years ago was the concept of STP capital. So what was it called? Sustainability and Transformation Partnership Capital, where you could bid for things that were sort of slightly more mid-scale, that sometimes for us sort of across West Yorkshire, so things like the Red Kite View, things like the HRA and CRH models were a good example. And we've consistently lobbied, as have other colleagues, to get that back on the table, because it's those things that don't quite fit into either category that we're a bit hamstrung on at the moment, given the funding arrangement. So, you know, we keep pushing that collectively. I guess I'm just saying that's where we're at the moment. Yeah.
Okay. This feels like we need to have a focus on or a key update report at our next board meeting. Again, it's sitting as a key risk. It's not even just one trust. It is so many trusts that we need to support. We take that point on some optimal conditions in delivering care. So let's keep having discussions on that. And that, for me, that's a really helpful lobbying point that we can take out. I really want you to give you a break. We've got about an hour left of our public meeting, our meeting in public, where we have a number of things to look over, including around strategy, planning, policy and commissioning. And then we will bring to a close our board meeting in public, and then we have some time together in our private discussions. So we'll just end the live stream for that moment and take a 5-minute break.